Hello, everyone. Thank you for coming from the last session and for joining us now to talk about and look at Maternal Mortality Review Committee criteria for determining the pregnancy-relatedness of suicide and unintentional overdose with Dr. Marcela Smid from the University of Utah. Marcela Smid is an assistant professor at the University of Utah Department of Obstetrics and Gynecology. She is a maternal fetal medicine specialist and dual boarded in addiction medicine. She's medical director of the SUPER-RAD, which is just a wonderful acronym, which stands for Substance Use and Pregnancy Recovery Addiction and Dependence Clinic, and an OB Air Med team member dedicated to the maternal transport team. She has worked internationally in maternal health in Zambia, Thailand, Mexico, and South Africa. Her research and clinical interests include perinatal substance use disorder, maternal mental health, understanding causes of preventable maternal mortality, and improvement in maternal transports. I know Marcela as a valued team member of the Utah Perinatal Mortality Review, and also just part of our wonderful national work together to prevent maternal mortality. So Marcela, please take it away.
Thank you so much, Julie. I am really pleased to be here and really honored to be here amongst these amazing speakers, and I'm delighted to just be a part of this. And I hope that this is, I hope next year that we are all in person and that we're able to make personal connections and have a conversation and a dialogue, and hopefully that will happen today. So what I'm going to present is an opportunity and an introduction and an invitation to a conversation. This is nothing that is being presented today is set in stone. So I just wanted to go over my disclosures. I am on the medical advisory committee for the Gilead Science Incorporated for hepatitis C treatment for pregnant and postpartum women, and part of my work was funded by the NIH K-12 Women's Reproductive Health Research Grant. And then I am the medical director of the SUPER-RAD clinic. This is Jasmine Charles, who co-runs the clinic. She's the clinical director, and it's a specialty prenatal clinic for pregnant and postpartum women with any substance use disorder. And so that's where, and then serving on the Perinatal Mortality Review Committee is largely where my lived experience comes from. And so what I wanted to review today was reviewing drug-related and suicide pregnancy-associated deaths in Utah and in other states that have published about this. And then the development of the Utah criterion, I'm putting air quotes in because that's what has been sort of dubbed as the Utah pregnancy-related criteria for drug-related deaths and suicides. And then lastly, I'll talk about the national criteria, which we are developing, hopefully using a Delphi method. And I'll talk a little bit about what that is. And there may be an inbox, in your inbox sitting an invitation to this Delphi method for your perinatal mortality or maternal mortality review committee, which I hope that you will accept. So the power of maternal mortality review committees in addressing substance use and mental health is really the same as that of any other pregnancy-related death. We can see that tip of that iceberg is death. And by reviewing those deaths and really understanding, and to the speaker from this morning's point, really listening to those stories, we can hear the common themes related to maternal overdose deaths and suicide deaths. And by doing so, we can prevent those deaths, reduce morbidity, and overall our goal is to improve the health of women in this country and even potentially internationally. And as we know, the MMRC form has, even in my time, evolved in order to really draw attention to the importance of maternal mental health conditions other than substance use and substance use disorder contributing to the deaths. There, even when I started, manner of death was the death considered a suicide was a box, but these are really important ways that we track this through the Maria system. And then individual MMRCs are doing this in different ways, which is why we're having this invitation to this conversation. So what I'm going to do is review the Utah Perinatal Mortality Review Committee's drug-related criteria, how it was developed. I will touch on two other states, Ohio and California, how they've looked at drug-related and suicide deaths, and then we'll go from there. And then I'll review kind of the next steps that how we developed our drug-related and suicide criteria. So this was the first paper that one of the first papers, I should say, that we published out of the Utah pregnancy-associated deaths from 2005 to 2014. This was a really great collaborative effort between the university members as well as the public health members on the team. And much like other states, pregnancy-associated deaths, over a quarter of our deaths were drug-related. Now, just to be clear, this included both accidental overdoses and suicides that were drug-related. And so this is a way that we chose to categorize any drug-related death. And this is all pregnancy associated. So some of these deaths were pregnancy related, but they were all pregnancy associated. Polysubstance use, much like the rest of the country, is really the name of the game. And 83% of women who died in pregnancy or in the year postpartum had 2 or more substances in their system found at the time of death, documented at the time of death. And 2/3 had 3 or more substances. Overwhelmingly, opioids were present in over 3/4 of women, followed by benzodiazepines, which included over-the-counter medications, antidepressants, amphetamines, muscle relaxants, and so on. Even in the time, so this is 2005 to 2014, our opioids have gone, our proportion of deaths related to opioids has gone up, and concomitant with the rest of the country, fentanyl-associated deaths have also increased, as well as out in the West, methamphetamine-related deaths have increased for us as well. And so these are some of the characteristics of the 35 women who died of drug-related deaths during this time period in Utah. Substance use or drug misuse was known in over half the cases. However, in 46% of cases, drug use or substance use disorder was not known. And I think that's an important number to really highlight. 3/4 of women were known to have a mental health diagnosis. Over 1 in 5 had a prior suicide attempt. Over a quarter had prior overdose event. 17% had a prior mental health hospitalization, and over a quarter had a history of lifetime abuse, including emotional, mental, physical, and sexual abuse. And to note, this is what is documented in the available records that we had. And so I would say that likely this is underdiagnosed or underrecognized. So the fact that we're seeing such high rates among the women who died of drug-related deaths, likely that speaks to someone had to ask and actually write it down for us to be able to find. If we had prospectively collected this data, I suspect that many of these numbers would actually be higher. And drug-related deaths are predominantly occurring in the postpartum period. So 80% of drug-related deaths in Utah occurred in the late postpartum period, so 43 to 365 days postpartum, as opposed to 1/3 of deaths from other causes. And so now I'm going to move to Ohio. Ohio published recently a research letter in the Green Journal, and they looked at their pregnancy-associated mortality due to accidental drug overdoses and suicides from 2009 to 2018. And from 2009, the individual year number ranged from 1 to 6 and did not substantially increase. However, that is not true for accidental overdoses. So in 2009, Ohio reviewed 3 deaths that were pregnancy-associated deaths due to accidental drug overdose. And in 2018, there were 29 deaths. And so accidental overdoses, there were 103 deaths during this time period. And they calculated 5,466 years of life lost due to these accidental overdoses. And 100% of these accidental overdoses included opioids. For suicides, there were 29 suicides that occurred during this time period, and 1,579 years of life were lost for suicide in Ohio during this time period. And firearms actually contributed almost half of these deaths, 45%, followed by suffocation and hanging, which is almost 1/3, and then intentional overdose was 10%. We are having a national conversation about firearms, but we do know from public health data that if you have access to a firearm, that you are much more likely to complete, and women are increasingly at risk of completing a suicide with firearms when it's available. And then California also published, they published their review of pregnancy-associated mortality review, their suicide, what they refer to as the suicide cohort, from 2002 to 2012. And these were, I pulled out some of the interesting things that they report, which I think is important in the way that we thought about developing our pregnancy-related criteria, which we'll get to next. So reproductive loss, there was this is all women who had a death related to suicide in California. And so pregnancy loss was 10%. So the most recent pregnancy had some sort of pregnancy loss. Social loss was 14%, so associated with loss of custody of child, either to foster care, child protective services, adoption, or a child living with another adult. A prior pregnancy loss was almost 30%. So this is really over half of the women in this cohort from 2002 to 2012 had experienced a reproductive loss. And then the psychosocial factors, I think, that are really important to highlight in this suicide cohort is over half of women had interpersonal conflicts or arguments that were documented, that the committee could actually document. Substance use was related, or at least a precipitating factor, in almost 40% of deaths. Financial hardship, so over a quarter. Exposure to abuse and violence, again, over a quarter. As mentioned, the reproductive loss. Loss of a loved one, so either a child or an adult in this person's life, and then other social and economic issues, including housing issues, lack of social support, incarceration, and communication barriers. And what I wanted to pull out is some of the important findings of California, which struck me as related as we developed these pregnancy-related criteria. So over 60% in the California suicide cohort had a documented mental health condition prior to pregnancy, and another quarter had new onset of mental health conditions noted during pregnancy or after pregnancy, and only 1 in 8 women had no history of mental health conditions. Nearly a third of women in this cohort used illicit drugs or abused prescription opioids during or after the pregnancy, and heavy alcohol use was noted in 17% of women. And then finally, nearly 65% of women who died by suicide within 1 year of pregnancy experienced a precipitating factor in the form of a stressful life event, specifically an interpersonal conflict or a significant loss. And substance use was another precipitating factor in 29% of cases. And so now I'm going to move to the way that we've thought about in Utah these drug-related deaths and suicide deaths. So what happened in Utah? So as I mentioned, we reviewed our drug-related deaths from 2005 to 2014. And then in 2014 to 2015, we developed a criteria, or when we were reviewing, I should say, those deaths. So it wasn't in 2015, it was when we were about to start reviewing our 2015 deaths. We developed these criteria, and I'm going to go over those criteria now. And this was done in a really iterative process. So after we wrote this paper and published this paper, we then reviewed those deaths and came up with a list of a way that we thought conceptualized how is pregnancy relatedness established both in suicides and these drug-related deaths. And this is what happened when when we had these prospective criteria, the rates of pregnancy-related mortality ratio increased. And it was because we were categorizing deaths in a slightly different way. So this is the paper that was published in the Green Journal and looks at and this is the flowchart of how we thought about and identified the cases. It's very similar to other maternal mortality review committees where we identify potential cases. We look at the relevant documentation, our amazing abstractors get all of the relevant details and put it in our case report. We present our multidisciplinary perinatal mortality review committee. Our committee meets monthly. We have representatives from maternal fetal medicine, addiction medicine, obstetrics, midwifery, nursing, our rural hospitals, public health, maternal and infant public health officials. We have maternal mental health specialists. We have addiction specialists from our public health department that come, and among others. And so we have a really diverse committee. And then we ask, as we all do, had she not been pregnant, if this woman had not been pregnant or postpartum, would she have died? And this is ultimately how we determine pregnancy and relatedness versus associated but not related. And so the first criteria that we came up with, so we followed the CDC's recommendations, and so a pregnancy complication, and this is the way that we have conceptualized this, is increase, so 1A is increased pain directly attributable to pregnancy or postpartum event leading to self-harm or drug use that is implicated in a suicide or an accidental death. And we actually had no examples of this during this time period. So this was 2015 and 16. 1B is traumatic event in pregnancy or postpartum with a temporal relationship between an event leading to self-harm or increased drug use and subsequent death. And so these traumatic events, as you heard the other committees in their reports talk about even traumatic delivery events such as stillbirth, a preterm delivery. We included diagnosis of a fetal anomaly, a traumatic delivery experience, relationship destabilization due to the pregnancy, removal of children from custody. And this was most frequently, this for pregnancy complications, there were 7 times that we identified this in an accidental drug-related death and 1 time for a suicide. And then our last one is a pregnancy-related complication likely exacerbated by drug use leading to subsequent death. So in these 2 years, we didn't have an example of that, but an example might be placental abruption in the setting of stimulant use. Our second clump of pregnancy-relatedness is the chain of events initiated by pregnancy. And so we thought about cessation of attempted taper of medications for pregnancy-related concerns, for example, neonatal or fetal risk, or fear of child protective service involvement leading to maternal destabilization. And so this can be related both to substance use, pharmacotherapy, or medication for opioid use disorders such as methadone or buprenorphine, psychiatric medications, or even pain medications. And we identified 2A as being the criteria under which pregnancy-relatedness was determined for 3 cases in a drug-related death and 1 case for suicide. We also included, based on that, the prior review of deaths, inability to access inpatient or outpatient drug or mental health treatment due to pregnancy because either healthcare professionals were uncomfortable with treating pregnant women or facilities weren't available. We had no cases in 2015 and 16 for that. And then perinatal depression or anxiety or psychosis resulting in maternal destabilization. An example of this might be depression diagnosed during pregnancy or the postpartum period resulting in a suicide. We did identify 1 drug-related case and 2 suicides that would fall under this criteria. And then the most frequent criteria was recovery or stabilization of a substance use disorder achieved during the pregnancy or postpartum period with a clear statement in the records that pregnancy was the motivating factor with a subsequent relapse or return to use with subsequent death. And so this was identified in 5 cases of drug-related deaths. And the return to use was often related to an overdose because of decreased tolerance or polysubstance use. And then finally, an aggravation of underlying conditions by pregnancy. So the most frequent for suicides was this first one was 3A, worsening of underlying depression, anxiety, or other psychiatric conditions in pregnancy or the postpartum period with documentation that the mental illness led to increased drug use or self-harm and subsequent death. And so an example of this, and the most frequent example, was pre-existing depression exacerbated, particularly in the postpartum period, leading to suicide. And we had 1 drug-related case that fell under this category. The other two remaining were not identified in 2015 and 16, but had we had these criteria, might have been pregnancy. We might have classified other deaths as pregnancy-related in the time period that I mentioned before. And those were exacerbation or undertreatment or delayed treatment of a pre-existing condition in pregnancy or postpartum, leading to increased prescribed or illicit drugs. So for example, chronic pain that's undertreated, leading to the misuse of medications or use of illicit drugs that led to death, or a medical condition secondary to drug use in the setting of pregnancy or postpartum period that's attributable to pregnancy-related physiology and increases the risk of complications leading to death. So this might be stroke or cardiovascular event due to stimulant use, such as methamphetamine use, which we know pregnancy increases the risk of stroke, and stimulant use may exacerbate that. Julie, how am I doing on time?
We have 10 minutes until Q&A.
Okay, 10 minutes until Q&A, great. Okay, so this is the pregnancy-related deaths that we categorize by the different categories. So overwhelmingly, we saw that pregnancy complications and chain of events were the most frequent times cited for both for accidental drug-related deaths. And then for suicides, the aggravation of an underlying condition was the most frequent category that we categorize under pregnancy-related deaths. And it was most frequently the pre-existing condition that was exacerbated either by the pregnancy or the postpartum period, or sometimes a combination of medication under treatment or changes in medication. We did see the same pattern that the blue represents in this bar graph, other pregnancy-related causes. Black is accidental overdose, and gray is suicides. That the overwhelmingly deaths are occurring in that late postpartum period. And we're seeing that across the country. So that's certainly not unique to Utah, and really the pattern that we're seeing pretty much everywhere. So when we applied these pregnancy-related criteria versus associated criteria, we were able to, in 2013, so the 2 years immediately preceding the establishment of these criteria, we classified 2 drug-related deaths as pregnancy-related. However, in 2015 to 16, we classified 10 deaths as pregnancy-related. And for suicides, in 2013 and 14, we didn't classify any as pregnancy-related. And then we classified 7 as pregnancy-related. And there was no change in the proportion of other pregnancy-related infections from those 2 years prior to the 2 years after we had those criteria established. So I wanted to read a couple of case scenarios and pose to the group. This is more of a thought experiment. We don't necessarily know the answer to this, but I wanted to propose this, and then we can have a conversation about this if time permits. So this is a made up example, but I wanted to present it for thoughts from the group. So 21-year-old G1P1 who delivered at 37 weeks via C-section. She had a history of opioid use disorder and a prior cesarean delivery. She'd had 3 prenatal visits and presented to labor and delivery and requested a repeat C-section. Postoperatively, she made multiple requests for pain medication for postoperative and back pain. On postoperative day 3, she was found in the bathroom of the hospital holding a syringe. A rapid response was called, and resuscitation was unsuccessful. She was pronounced dead at 45 minutes of the resuscitative efforts, and an autopsy and toxicology were consistent with an acute heroin and fentanyl overdose. So would we consider this death pregnancy-related versus pregnancy-associated? So based on the criteria that we have established, this might fall under 1A. So increased pain directly attributable to the pregnancy or the postpartum event, such as a cesarean delivery, leading to self-harm or drug use that is implicated in suicide or an accidental death. Now, this death occurred in this fictitious death, although there are deaths that are similar that have occurred across the country, occurred in the hospital with excellent documentation. But what if the timing changed of this and this death occurred 6 weeks postpartum versus 6 months postpartum? And I think all the committees struggle with the level of evidence and the amount of documentation that we have in which we're able to establish really a direct association between the pregnancy or postpartum events and the death and that timeline. And so collaborative information might include that a woman called for additional pain medications to an OB office. And if that had happened within that 6 weeks postpartum, is that enough evidence for us to establish that as pregnancy related? It might be, but what about in the 6 month? What if this death occurred 6 months postpartum? If she had called in that 6 week period, but the death didn't occur till 6 months postpartum. One thing that has been very helpful for us and was discussed yesterday is the informant interviews or these verbal autopsies that occur that really help establish a timeline and understanding of a more contextualized understanding of a person's life course that may have led to their death. And so if a partner on a police report stated that self-medication had been something that this woman who died had been engaging in to deal with increased pain directly attributable to a C-section, is that enough evidence? And so these are really questions to pose to the group. And we've struggled with these questions as well. The way we've handled it is to really discuss, do we have enough evidence to point to the pregnancy or the postpartum event as being a destabilizing event in this woman's trajectory? So another drug-related case, a 29-year-old G3P3 who delivered uncomplicated vaginal delivery at 39 weeks. She had a history of OUD and had been stable on methadone. Her 2 other children had been removed from her custody and were living with their grandmother. This pregnancy, she'd been on methadone and had stopped going to the clinic because she was worried about her children being taken away from her and withdrawal symptoms in the infant, which was recorded in the prenatal chart. At 34 weeks, she was found unresponsive in the bathtub by her partner. He called EMS and she was declared dead on the scene. So this is this case I present as a pregnancy pregnant in pregnancy. And so this might fall under, for example, 2A, that cessation or attempted taper of medications due to pregnancy-related concerns, both concerns for child protective services and concerns for neonatal withdrawal symptoms. And so we might classify this, I suspect that we would classify this as a pregnancy-related death. But what if that had occurred 8 months postpartum? And the death, the initiating event was that this woman decided to decrease or stop going to her methadone clinic because of the pregnancy, but the death didn't occur until 8 months postpartum. Would we classify it as pregnancy related? I think that depends on the collaborative information that we have available. So what if there was a note in the prenatal chart that she appeared on edge at 33 weeks, and then later at 8 months postpartum, she had custody of the infant, but a survivor interviewed the mother of the deceased report that the partner or father of the baby had a return to use, which led to her return to use of the decedent. I think this we struggle with is having the question that we fundamentally want to answer is, had she been pregnant or postpartum, would she have died? And so having a child and having a father of a baby that comes back into your life, is that a pregnancy related death? And I think we've had conversations in our own PMRC where sometimes we've classified it based on the amount of evidence as pregnancy related, and sometimes we say we're not sure. And then finally, a suicide death. And Julie, I'm going to do one more time check. How's my time? So I want to make sure I leave enough time for questions.
2 minutes.
2 minutes. Okay. So then I'm going to skip this one because it's really just posing the same question around a suicide death and how it would fall under our, in this case, I would have classified it as in 3, aggravation of underlying condition by pregnancy. But we will skip that. So I wanted to just review our what we're doing for establishing these national criteria, and in collaboration with Julie and others from the CDC. So this was a recent publication for pregnancy-related deaths in the United States from 2011 to 2015. And deaths attributable to suicide, drug overdose, homicide, and unintentional injury were excluded from this analysis. And part of that is because we all classify and we all review our deaths very differently. And even over the time period that I've been involved with the PMRC here in Utah, we've changed the way that we've classified and really established these criteria as a tool to help us be more objective and say, does this follow a pattern where we can really draw a distinct line between the pregnancy or postpartum periods to this woman's death. And so this is what we're doing with the Delphi method. And the Utah criteria is meant to be a living document, and this is why we're presenting it here. We think that timing and collaborative information are two really important things that really distinguish whether or not we're able to establish pregnancy relatedness or not. And we're working on this national criteria using a Delphi method, and many of you may have that invitation sitting in your inbox. And so this is the team that's working on it. This is Chris Campbell is up at the top. She is a child fatality, she's a child abuse expert. She's a pediatrician, but has experience with using a Delphi method for establishing national criteria for near child fatalities. Portia Vaughn is a librarian, and she is working with us to make sure that we are moving forward with all of the projects. And then there's Dave Goodman, Julie Zaharatos, Christine, and Tegan, who are also part of this team, and we're utilizing the Delphi method. And the core of the Delphi method is to have anonymous feedback from experts, and you are the experts in this. So this is why we're requesting that you participate in this and help us establish these national criteria so that we can all be talking about the same thing when we really address the suicides and drug-related deaths as from a pregnancy-related criteria. So we're still in that first phase. We've sought individual assessments from our pool of experts. You are our pool of experts. This is my plea. Many memes will be sent to you. Please answer the email and fill out the demographic survey about your MMRC if you are the point contact for your MMRC. And then we're asking that you select an MMRC representative that is knowledgeable about the process of establishing relatedness versus associatedness. And the time commitment's about 40 minutes for 4 rounds. And we will provide you with a gift card. And today will be a good day and we'll for your time. And we're really asking that you help craft this national criteria so we can improve the way that we talk about this and really be able to, the large goal, right, is to prevent these deaths and to prevent maternal morbidity from suicides and drug-related deaths. So now questions. Many questions. There may be questions. I may have evidence-informed, not evidence-based answers. I will certainly have lots of opinions.
Awesome. Thank you so much, Marcela. That was wonderful, as always. We did get quite a few questions and comments in the chat, which is wonderful. We have a very engaged group today. I have some questions, but I know that we only have 10 minutes and there are folks with some burning ones. So Beth from Tennessee asked, with overdose deaths, we often find it challenging to obtain this information within the documentation. How does Utah manage decision-making with gaps in the record? Is the criteria highlighted in the abstractions or narratives that are presented to the committee?
Beth, I think that's the $1 million question. So I think because our abstractors have been involved both in the discussion about these criteria, but also in the development of these criteria, it was really an iterative process that the entire committee undertook. They have an eye for this when they're abstracting the data. So when they're really looking through all of the different documentation, the police reports, social media, our abstractors go and look on all of the different social media sites, obituary sites to look for any evidence. There is an eye towards being able to identify any collaborative information about whether the pregnancy or the postpartum period was a destabilizing event. So I don't think that we haven't had sort of the, I'm imagining a case narrative with sort of highlights, but we do, from a very practical perspective, when we have a suicide or a drug-related death, we actually pull up the criteria and one by one go through the criteria and see if it falls into our criteria. And sometimes, and we've done this really fairly frequently in the recent past is we've said, there is some evidence, but not an overwhelming amount of evidence that this is pregnancy related, but we think there might be enough evidence to say that it's pregnancy related, but we're not really sure. So we've classified them as unable to determine. And for us, that's been kind of the middle ground of being able to really say, do we have compelling evidence where we can draw that line? Two other things that have really helped. One has been informant interviews. When we do have informant interviews, those have been incredibly helpful because those are questions that informants are asked, questions that don't necessarily appear in hospital records or EMS records or police records. And I would suggest that we might want to think about, for informant interviews, really asking directly, do you think that the pregnancy or being postpartum was a destabilizing event and contributed to this death of the folks that either the partners or the family members or the friends of the decedents? And then the other tool that's been very helpful is in our opioid fatality review committee for the state, that one of our abstractors has really come up with these beautiful life course models where the risk factors and protective factors are highlighted, and you get really an entire picture of an individual's life context of not just the snippet of pregnancy and postpartum. And that obviously takes lots of time and money and effort to obtain that information. But we have found that to be a really helpful tool to sort of conceptualize how the pregnancy and the postpartum period fit into this person's overall life trajectory.
Great. Thank you so much. One key feature that stands out to me, besides the criteria, is having MMRC members that are subject matter experts in maternal mental health and substance use disorder. I know you have those, and I just wonder, I think, in the context of the presentations we've heard over the last 2 days, do you have or are you considering having someone with lived experience in maternal mental health and substance use disorder on your committee?
So we've also had that conversation about having folks from community organizations. So for example, in the Super Rad Clinic, we have peer recovery coaches who are folks that have walked that walk. They don't just talk the talk. They've lived through a substance use disorder and in recovery and are now working as peer recovery coaches, helping other individuals in their recovery pathway. And sometimes they're very close to their recovery. They're not very far out, and that lived experience is really close. And for some folks, it's 2 decades out, but they really engage in very different ways, and they're all very valuable. And we've had conversations about having those folks be a part of reviewing these cases in order to provide that additional context of what does a person who is living this really experience. What is and many, particularly our young peer recovery folks, have had the lived experience of that CPS, of the fear of CPS, of Child Protective Services, and our parents and our parenting, and have lost custody of children, and some have regained custody of children, and so that I think has been incredibly helpful to from my own experience working with them and hearing about their process, and we've had conversations about inviting them to the table. That's
wonderful. Thank you. I have heard of one other state that does have a peer recovery coach on their committee, and it's wonderful. But they have also considered compensation models for that individual. So it's great to hear. We did get an audience question that I do think is a relevant segue, and we only have a couple minutes left, but that the interconnectedness of overdose and discrimination. And, I think thinking about the tools on the Maria form, do you all see or are you able to flag potential discrimination as a contributor in cases?
That is such a great question. I'm so glad somebody asked. So I think we've struggled to really establish from the evidence that we have available in the record discrimination. On occasion, there have been things noted, such as, she didn't, for example, something like if she, she went to the emergency room where she attempted to seek treatment, for example, for a drug-related death, but felt discriminated against or felt judged or shamed because she was pregnant, and she was continuing use. We've had a couple of cases of that, but that's really the exception rather than the rule. And so I think we've had conversations about what are other tools that might be helpful to include discrimination, because oftentimes we see that at a population level, not necessarily, at least not the medical record is not so great at capturing that individual discrimination. And certainly in Utah, we have discrimination. We certainly have rural versus and frontier and rural areas where we simply don't have access in certain areas, and certain populations are not offered the same level of services as other populations. So we've had conversations about utilizing things like geomapping and the number of treatment providers or the number of maternal mental health specialists in certain areas that are able to provide the services that might have changed the trajectory of a woman's life.
Yeah, unfortunately, we're out of time. I think we could talk for a long time about this, but about methodology of communicating the changes in the pregnancy-related mortality ratio with these criteria, but let's continue the conversation another time. We deserve to give folks a break, and then we will reconvene at 2:15, at 1:55. Talk to you all soon. Thank you. Thanks, Dr. Smid.
Everybody, thank you.
Bye.
Bye-bye.